All right, our next speaker is going to be Dr. Conley. He's an assistant professor of sarcoma and medical oncology with expertise in chemotherapy for chordoma.
Hi, good morning, everybody. I'd like to thank the organizers for allowing me to discuss a little bit of what we do. So I'll start by just giving a brief outline. Clearly these are topics that any one of us could extend to an hour and beyond. And so I'll just briefly introduce my role, go through the current landscape, which is still lacking tremendously, go over sort of the method that I use when I see patients in clinic, and then I'm going to steal maybe 5 minutes of that time to talk about something that we've been doing for different disease type that could easily be adaptable for chordoma. So as was mentioned earlier, chordomas are extremely rare. Survivability is something that we still want to improve upon, and it's clearly a disease where, let me see here, we see more of it as we advance in age. So there are some folks that are affected with this disease at an early age, but most are usually adults or older adults. So importantly, what is the role of a medical oncologist? So as everyone has stated previously, the most important thing is this. Chordomas are diseases that are generally treated and cured with surgery and radiation. The only time when you really need a medical oncologist is if you've got a situation where the disease has not either been controlled prior to seeing a medical oncologist, or if the patient at diagnosis has already been diagnosed with advanced disease. So, and I also see my role as more of like a primary care physician for cancer patients. So, what can I do to direct you to the right people if you come to see me first, to the radiation oncologist, to the surgeon, to any of the folks that deal with the comprehensive care of chordoma patients? Well, the National Comprehensive Cancer Network is a collective of multiple centers that provide a tremendous amount of care for patients, right? And we we meet regularly to formulate or incorporate the best data to help us figure out what we can use to treat patients. Well, as has been discussed earlier, chordomas are generally diseases where we don't use chemotherapy often. In fact, the only time we ever consider use of chemotherapy is in patients that have what we call dedifferentiation. And this is a process where we think the original tumor has now undergone morphologic changes so that it is a much more aggressive variant akin to other high-grade sarcomas that have a much greater chance of spreading to other organs. In terms of what we do use right now are generally what we call targeted therapies, many of which here in the room are probably familiar with. So, the most studied targeted therapy for this disease is really imatinib, also known as Gleevec. Gleevec is a drug that blocks the function of a variety of proteins. We think about it in CML, chronic myelogenous leukemia, where it blocks a fusion protein. We think about it in GIST, gastrointestinal stromal tumor, where it blocks the c-KIT protein. And for chordoma, we think about it because in chordoma, we essentially have a higher expression of certain proteins called platelet-derived growth factor receptor. There's alpha and beta. And in fact, imatinib actually blocks both. So there have been about 5 studies conducted, one of which has been a phase 2 trial looking at about 133 patients collectively. And as you can see, the response rate's really sobering. So, unlike some of the really cool stereotactic radiation pictures where you see things melt away, a lot of the systemic therapies we use don't seem to exert that same level of effect. And mind you, a drug like imatinib does work differently on a cancer cell than what you would expect with radiation, or for that matter, if cytotoxic chemotherapy could effectively concentrate into these cells. What we do see is a tremendous amount of stable disease. And while that's not as exciting as seeing dramatic shrinkage, we have to take into account what that means. Well, if we can't always effectively eradicate the disease, what can we do to at least extend survival and improve quality of life at the same time? And so oftentimes we'll look at things like stable disease as a way to do that, and also considering whether or not the treatment is one that's going to be toxic for the individual or not. Now, in general, what we've seen is that the progression-free survival is roughly around 9 months. What that means is that, in general, when patients start taking Gleevec, most will have the disease progression, the growth of the tumor, offset by up to about 9 months, though there's a range. There's some folks that will experience better outcomes than others. I mean, for instance, this is a patient that has metastatic chordoma, and in this case, his disease is essentially in front of where the prior surgical region was. And what we've used here is a PET CT scan. And just briefly, while for localized disease, imaging such as MRIs and CAT scans are effective, when we're dealing with advanced metastatic disease where these tumors have actually gone to other completely different organs, visceral organs like the lungs, or structures within the belly, sometimes we like to use PET scanning as well, because this will help us not only look at what's going on with the size of the tumor, but how active is it? And when we talk about response, oftentimes, at least in medical oncology, we're used to using metrics where we're looking at two-dimensional changes. Well, tumors aren't just two-dimensional. What's also going on with the activity, its ability to metabolize or use or produce energy. And so even with Gleevec, we have patients where you'll have a really hot tumor where it's using a lot of sugar to make energy, and where you essentially have it eradicated. Now, I mean, this is kind of the exceptional type of responder to imatinib, but clearly there's some folks that obtain benefit. Now, the problem is, though, that it's not a permanent fix. So you're on Gleevec for 9 months, progression starts to set in, and for some folks, that also equals more symptoms. And so at that point, what has been looked at in the past by fantastic investigators in Italy has been to complement the Gleevec by adding other agents. And so, and part of this goes into biological rationale that in the scope of 10 minutes is really difficult to discuss, but essentially there's a pathway called the MTOR pathway. And it's one of these pathways that helps cells in general to survive. And we find that with many types of cancers, the MTOR pathway is not overregulated, but overactive. And so there was Stocchiati did a fantastic study, very small study, of course, where she was combining sirolimus with imatinib and actually was able to induce some responses. And even though we're, here on the slide I mentioned 7 patients with stable disease, importantly, when we look at response with chemotherapy or systemic therapies, it's more of a range. So it's not absolute. So if your tumor grows by 2 or 3 millimeters or shrinks by several millimeters, that doesn't necessarily mean that you've had a response. In general, with the criteria we use, it's considered stable disease. And this can be kind of confusing for patients. Sometimes when you get a radiology report, it'll mention, patient's 10-centimeter tumor grew by 3 millimeters, and in the impression it says progression of disease. And sometimes we have to just, I get a little headache off of that because I'm trying to explain, well, yes, it's grown just a little bit, but let's think about it in the context of how are you feeling. If you're feeling fine, your quality of life is good, let's push through this a little bit more and see if we can actually stabilize this further, or if we see delayed response versus just immediately taking off the drug for a patient that could be benefiting from it. So sirolimus was one approach. A second approach is using cisplatin. Also, this is a drug that actually we've used here many more times than 6 times here. But essentially cisplatin is an older drug, but it has a very good ability to concentrate into bone tissue. In fact, it's probably one of the best systemic therapies to concentrate or saturate into bony matrix. So, we use this for osteosarcoma, we use this for chondrosarcoma, and so what we've seen when we add cisplatin to imatinib is that oftentimes we can rescue a little bit of resistance. In other words, you're on the drug for a while, the disease starts to grow through it, you add the imatinib, and in some cases we've seen patients actually have response, or at least shrinkage enough to improve quality of life by decreasing the amount of pain that they're experiencing. And just briefly, thanks to the Chordoma Foundation and some really great investigators around the world, there have been several phase 2 trials that have either incorporated chordoma patients or have been chordoma specific. And this is important because there's a lot of sarcomas. There's 150 types of sarcomas. And I can tell you there's a lot of diseases that are far more, rare diseases that are far more common than chordoma, where we have yet to establish the first trials for these diseases. So it's remarkable that for chordoma, the community has been able to mobilize and do what they've done. Now, we clearly need better agents, though. So, these are phase 2 trials that have been conducted over the last few years. Here, these were studies that involved looking at drugs that targeted the epidermal growth factor receptor pathway. This is a pathway that's not mutated, or where the genes are not mutated, but it appears that there's sort of upward expression or overuse of these pathways. And so what we see is that the progression-free survival, again, is around 8 months or so, and these are typically patients that have already had Gleevec. So, you're adding on a little bit more to what they may have had. But still, as you can see, the response rates are clearly subpar or suboptimal, correct? And so, what we need to do is find a way to salvage patients by thinking about a better strategy to get tissue and to maximize what we can do with this tissue. And then briefly, of course, brachyury, extremely important, a transcription factor that we think is paramount for the development or driving the development of this disease. And so there have been some wonderful folks at the NIH or NCI that have done a tremendous amount of work using a strategy where you basically take this protein that's really specific for this disease and generally not found in other normal tissues, particularly when you're an adult. And so it makes an attractive target for the immune system. And there's different ways to do this. So we have clinical trials here for other types of sarcomas where we use viruses, where we engineer the virus to, knock in a target of interest. And what it does is it presents itself to dendritic cells that will then present and help make T cells become specific for the target of interest. And so in this case, this is a technique where they used a yeast. And essentially what they were doing was priming the immune system to go after anything that had brachyury in it. Now, the results are ongoing, and importantly, even though we don't see major responses with this right now, it takes time. The melanoma field, it took 30 years of doing repeated vaccines. I remember as a fellow here years ago and being in melanoma clinic thinking, gosh, it's so tragic to see these patients go through this terrible disease. And here we are 10 years later, and suddenly it's become a disease that's drastically changed in terms of how effective the therapies are. And now, ironically, I look internally or introspectively and think, well, what can we do to do the same thing that has been done for melanoma, but for diseases like chordoma? And it starts with trials like this. We have to know how the immune system works when it comes to targeting chordoma, and what metrics can we develop to improve upon these results. And so, clearly, even with this small phase study, what we found were that patients could have immune responses. It did induce stability, but it alone was not enough to completely stave off disease. Now, again, importantly, we also have to think about, is this the best way for the immune system to be primed? Do we need to add other medicines that can help with that priming? And I think the answer is certainly yes. But this is an impressive beginning, though, a foundation from which I think we can build a much better immunotherapy strategy for this type of disease. And importantly, in keeping with what I was saying about melanoma, immune checkpoint inhibitors have become a really hot topic. There's commercials for two companies that I won't name here that advertise their product because there have been FDA approvals in melanoma, lung cancer, bladder cancer, lymphoma. And there have been actually several successful trials run in sarcoma where, we're not seeing all sarcoma subtypes respond, but we are seeing some activity. And importantly, there have been studies such as the study done by the Harvard group years ago where they are actually showing that some of the right markers for what we want to see to use these therapies in are present. So basically, one of the mechanisms by which the body is able to evade the immune system is it can produce proteins that will basically tell your T cells and other cells that are involved with immunity to stay away or to not initiate programs that will eliminate them. And so one of these proteins is PD-L1. There's clearly a lot more. PD-L1, PD-L2, CTLA4, just a whole slew of other proteins. And interestingly enough, there's actually a fair number, at least the samples that were tested, a fair number had a really high expression of these proteins. And so these immune checkpoint inhibitors work by basically removing that block, by removing those proteins. And so here's a patient that I treated after receiving the Brachyury vaccine, had previously been on Gleevec and another drug called Votrient, which I didn't talk about here. And at the time, we were able to get expanded access through a company to get pembrolizumab. And so we treated the patient, and this is essentially over a 6-month period. And what we see here, this is, of course, a paraspinal tumor. And initially, after starting therapy, the tumor actually got hotter. In other words, it got more active, slightly larger. And then if we look at this rib metastasis, we see the same thing. The really unique thing that we're seeing with immunotherapies, at least in sarcoma, and has been observed with other cancer types, is that you have to give it time. So if you've got a disease that's rapidly growing, that's causing pain, immunotherapy may not necessarily be the right step for the time being because it takes time. These tumors oftentimes become inflamed, they enlarge, they may actually become more painful, but if you continue treatment, what you eventually see is that the metabolism of this tumor completely changes, and we also see symptom improvement, and in some cases, tumor size reduction. And so, and again, this gets back to how we look at defining response, and it depends. In my opinion, if you have a patient whose quality of life has improved, both because the side effects of the medicine are less than what we usually give, and if the tumor has now become less painful and mobility has been restored, then this is very helpful. Now, the challenge to this type of technique in chordoma is going to be the following. Whereas with sacral chordomas, I don't see this being a problem at all as far as treatment. When you're dealing with clival chordomas, the difficulty is if you've got a tumor that's expanding in the brain, you're going to have swelling, which necessitates steroids. Steroids are wonderful drugs to help as anti-inflammatories, but unfortunately can sometimes limit the ability of these agents to do what they need to do. Although I will say, what steroids impart may not always abrogate or get rid of the potential of benefits of these immunotherapies. We've actually had patients where they've been on steroids, we've treated them with these immunotherapies, and they actually do well. But that's not going to be everybody. But it's exciting to see that this is one of the ways that we can do this. And there are actually at least two trials that are available right now in the United States evaluating the effects of these immune checkpoint inhibitors with or without radiation. Josh has actually, I think, has put this on the website for people to see. Clinicaltrials.gov is a fantastic resource for patients and clinicians to look at what trials are available globally that are registered. So I think it's important that if you're ever thinking about a clinical trial, whether it's at MD Anderson, Baylor, or anywhere else in the world, it's the repository to find the right trials through this clinicaltrials.gov. And so this will just lead me into how I treat. So when I see a chordoma patient that has advanced disease where surgery and or radiation has been ruled out, at least temporarily, I usually like to do next-generation sequencing. Now, next-generation sequencing, this is basically a technique where you target the genetic sequence of a variety of genes of interest. Usually these are genes that are involved with either prognosis or potentially helping us select better therapies. Now, there have been some really important papers published recently, such as in Nature Communications, where the UK group and some other folks from around the world, including Chordoma Foundation, helped publish a nice paper looking at the genetics of this disease. And so compared to like a melanoma, where there are a tremendous amount of mutations, we don't see that with chordoma. That doesn't necessarily mean that you can't exploit that for treatment purposes. You certainly can. And what I mean is the following. So if I get next generation sequencing and we find no mutations, fine. I start with imatinib, and we try to either add to that by adding a second agent, or if there's a clinical trial that's available, I'll try to put the patient on a clinical trial first, because we already know how imatinib works. What we need is to improve upon that. On the other hand, if we do find a mutation present, there are times where targeted therapies can occur. I mean, in fact, there was a patient that was shared between Sloan Kettering and MD Anderson where a mutation was found. for which there was a drug already FDA approved for another very rare type of disease. Fortunately, we were able to get access, and we actually saw really nice activity. Now, it wasn't permanent, but at least it helps buy us time to think about other strategies as well. And so I think it is an important step to think about when I see a patient is, okay, have you had sequencing? And this also brings about the other issue of access to tissue. You know, do we have enough tissue to do these types of things? When we do diagnostics, oftentimes the processes for the diagnostics can ruin our ability to do the sequencing. And that's not to say that what the pathologists are doing wrong. They're doing what they need to do. It's hopefully having, and more so pathologists in the community know that they need to save some of that tissue in case we're going to do things like these type of testing. But at every point, we try to consider clinical trial. So, to my last point. So for the last 2 years, working with some of our orthopedic surgeons for chondrosarcoma, one of the things that we've been doing with using protocols is thinking about, well, you know, we see an enormous amount of bone tumor patients, more so than most places in the world, and it's a wonderful gift for us. You know, we need to maximize what we do with those tissue samples. And so what we've done with our extremity chondrosarcomas now is that oftentimes, you know, I see the patient, they get their next generation sequencing just to see if there's any test results that can help us with treatment. Meanwhile, the patient ends up going to surgery. Our fantastic pathologist, Dr. Lazar, Dr. Wong, will do quality control, save a piece of that tissue. They send it to our lab, Dr. Patrick Hu's lab. He's currently division chair, and he's chairman of several departments at our institution, where basically we then use his lab as sort of like a core to then shunt it to a variety of places. And so cell line development, genomic analysis such as exome sequencing, RNA sequencing. We've donated tissues to our Institute for Applied Cancer Sciences, which is in some ways sort of like our own little pharma or medicinal chemistry department where they're actively trying to develop new drugs. We've also sent it to what we call TIL lab, Tumor Infiltrating Lymphocyte Lab, where we extract the white blood cells from the tumor. We phenotype them, meaning we characterize what type of white blood cells they are. We expand them out, we recharacterize them, and then we test them against the same tumor. And then if we do find any tumor-specific antigens or tumor-associated antigens of interest, we can actually have people like Cash and Yi who can customize or build T cells to target this. And so we've actually done this several times in chondrosarcoma where we've successfully extracted tissues, developed cell lines. We've done 3,000 compound drug screens, exome, RNA-seq, reverse protein phase array, immunopeptidome analysis, TIL, electron microscopy. I mean, it might be overkill, but the idea is essentially to use this type of technique to develop a database that we can use for in silico purposes. So if I say, you know what, I want to develop a trial for disease X, such as chordoma, what do we have at our disposal to help us? And so essentially, we've actually successfully done this several times now. I think that this is an approach that should be considered amongst chordoma. I think oftentimes we do this in silos, but if we could get together and do this as a group, I think effectively we're going to get faster results. And I can tell you with chondrosarcoma, we have gotten a tremendous amount of data, of which some of which we'll begin publishing very soon, but I don't see why we can't repeat this sort of model for this disease. I think it'd be great. So in conclusion, current treatment options from a systemic standpoint are insufficient. Clinical trials are currently always preferred, and we definitely need to incorporate a pipeline that can help us maximize the amount of tissue that we get to develop better therapies. That's it. Thank you so much for your time.